she is our contracted nurse through Oakland County. So she's going to be in servicing us on our medical.
Hello. This is my second year at Clarkston, so hopefully I look familiar. Some of you guys look familiar. The idea is we're going to go through a presentation and try and give you some a video on how to intervene effectively for students. So this is the agenda. This is part one. We spend most of the time in the areas of the plans of care. This is new this year. You guys actually have new plans of care. No one really understands it. It's not totally in operation. But the plans of care are medication, didn't really change. The next one is allergies, asthma, diabetes, and seizures. So those 5 plans of care is basically the presentation for today. So the second part of the agenda is just more quickly we go through it. It usually takes about a half hour to 20 minutes to a half hour. The objectives are that we really want you to have an understanding of when do you call 911 versus when do you intervene on a medical basis. The intervention is described by the plan of care. An ability to use an EpiPen, assist students with asthma, and be able to know the difference between asthma, allergic reaction, and anaphylaxis. They require different interventions. The other one is a choking person. How do you assist them? Verbalize how to do first aid management of cuts and nosebleeds. How to intervene for a seizure. CPR is important because people who have seizures can end up stop breathing and stop having circulation. Diabetics can get so low in their blood sugar that they stop breathing and that they have no heart rate. The other one is how to intervene for diabetic students, and then nutritional needs supported by tubes. So the idea is, in some cases, you are expected to know how to intervene for your students. If their parents submitted a plan of care, they did that because they want our help during the school day. If there is no plan of care, then you call 911. It's kind of simple. The other part about this slide is that I'm not the boss of anyone. My word doesn't go above your policies. You're still accountable for your district policies. So these are some ideas of this is when you call 911. So mental status changes are really important. I don't know if they hit their head, but chances are they hit their head, they're going to have a change in mental status. That's a 911 call. If a student has difficulty breathing and you don't know they have a plan of care for asthma or allergic reaction, you have to call 911. If there's a break in the skin and you can't stop the bleeding in 5 to 10 minutes, you have to call 911. Bleeding and head trauma is pretty easy. You're going to call 911. There's no plan of care for us to fix that. Student has a rapid heartbeat and it doesn't slow down after square breathing or like quiet talking to someone. That's probably an ingestion. Something was ingested that wasn't supposed to be and the heart is reacting to that. That's a 911 call. And a poisonous or foreign substance, those are 911 calls. We have no idea what that person took, how long it's going to take for them to recover, if they're going to have another medical need in the meantime. So the plans of care are basically what I'm describing through this process. We think that medications, allergies, asthma, diabetes, and seizures are the primary and the largest group of what we are going to be expected to intervene in. There might be other things, those would go to 504 and or IEP. But this is kind of a recipe card for teaching and training people how to effectively manage for most of the things parents will expect us to manage. So breathing difficulties are the first ones. Insect bites. This is the easiest one to talk about in terms of knowing the difference between an allergic reaction and anaphylaxis. As an example, I'm not allergic to bees. I'm out in the garden, a bee stings me, I have an allergic reaction. It's just right on my hand where the bee stung me, it raises up and it's kind of itchy. So I take a Claritin or a Benadryl, I feel okay. That's an allergic reaction. This year, I got stung by 3 ground bees at the same time. I said, okay, I'll just take a Claritin. So I go in the house, take a Claritin, go back out. I don't feel good. Something's not right. I'm kind of thick in my mouth. My face is starting to swell. I'm starting to get itchy. I'm like, what is this? So I go in, think I'm anxious. I jump in the pool. I'm like, okay, just cool down. Everything will be fine. Not fine. Kept getting worse. So I ended up taking another Claritin. Still wasn't better. Jumped in the car and went to the emergency room. By the time I got there, I had hives all over me, difficulty breathing, chest pain, and my heart was just beating. So anaphylaxis is more than 2 body systems. That's cardiac, respiratory, gut, and skin. So if 2 or more of those things happen, that's when we use an EpiPen. It's really important. So and food allergies are like that. Peanuts, we know that the more time someone gets exposed to an allergen that causes an allergic reaction, the more likely they move to anaphylaxis. So having peanuts, if you're allergic to them, is not a good idea. It just gets worse. So you guys know about histamines and all that kind of stuff. That's what we're trying to work against. This EpiPen is epinephrine. Epinephrine and norepinephrine are made in your adrenal glands. Your body is trying to react to that allergen, so it makes you feel nauseous. It gives you hives and prickly skin. You're trying to fight it off on your own. The EpiPen we give you is an enhancement of that reaction. So that is a really difficult side effect, but it's no worse than not being able to breathe and dying. So it's an enhancement of those 4 body systems. That's the side effect someone's going to get if you give them an Epi shot. That's just an explanation of anaphylaxis, and then this is the EpiPen. So everybody knows there's a blue, this is a trainer, so I'm not going to poke myself with an EpiPen. This is a trainer. You pull the blue part off, and you see how I hold it to the outside of someone's skin. You should hear the pop. The first time you didn't hear it, so it didn't go in. Now it went in. You hold it for 10 seconds. You have to hit somebody pretty hard with it in order for it to pop. Go ahead.
Well, if you're not sure, you can just pop them 3 or 4 times.
You've got to hear that click. So the idea is to make sure that if...
A lot of people are talking around and it's noisy and you don't hear it, but it does click. If you hit them again with it, it's not...
It's not a good idea because I don't know where that needle is in that process. I need you to hit them hard enough in that first click. Hit on the side of too much, not too little. Because if it's somewhere in between, I don't know what's going to happen the second time you try to do it. I need you to pop them. You hear it? 10 seconds. This is an EpiPen for a student who has an allergic reaction. Do you all know that every building in Michigan, school buildings, have to have unknown EpiPens for people who are unknown allergens? So during the school day, if anyone has an allergic reaction, is unknown to us, no plan of care, there is 2 EpiPens in every building so that you can rescue them. So a failure, if you will, that you don't know if that person, if you can't see that that needle popped out when you pull it out and you're scared you didn't get them, there's another source for you if there's not a second EpiPen around. It's the unknowns. Does that help if you make a mistake and you're not sure? It's really important to hit them hard. Go ahead.
Where do they keep the unknown EpiPens? Is it in the counseling office?
I'm not sure. Every school keeps them in a different place. So,
It's in the main office on the wall. If you're looking at Judy's desk, further back, just to the left.
It's really important that we use these because this was a mom whose football player's son got stung by a bee out on the football field, and that was before 2014. In 2014, by the end of the year, the legislature in Michigan passed a law that all schools have to have this. Everybody okay with that? Any other questions? You can practice with these down here if you'd like. So this is just a little bit more about the same, so I'm not going to belabor it. We go into asthma. Asthma is a big, big deal. It's as big a deal as anaphylaxis. If these kids start school with inhalers and they're asthmatic and there's a plan of care, I hope by April they still have them and they're accessible to those students. These students usually in this year, these age groups, they carry their inhalers. And they need to have access to them. If they get a reaction, it can be by the environment, so heat and cold changes can trigger. Anxiety can trigger, smells, perfumes, any of that kind of stuff. Those can all trigger an asthmatic exacerbation. If they have that, they need their inhaler for relief. If they puff 2 times, a second one, if they're not better, they're instructed to do that same process a second time. Their doctors have told them, their parents have told them. If they're not getting better after that, they take the second one. If they're not getting better after the second one, it's calling parents and 911 if they're not getting better. You guys lost a little kid in the district a year ago. His mom was with him, and he was at school, and they were getting ready for the school year to start, and he tried to puff, and it didn't work. She put him in the car and took him down I-75. They stopped at the fire department because they thought it would be better and they could help him. He didn't make it. So asthma is a very important thing. Our kids need to have their inhalers. And you guys, to support them, coughing, or when you see somebody using the accessory muscles of respiration, those are your diaphragm and your shoulders, because you can't get the air in, they're in trouble. They're in trouble already. Make sense? You don't care about the types? So these are what they use. That's their puffer. They'll call it a puffer or inhaler. This is for younger kids. It plugs into an outlet, and we put the medicine in the cap up there, and it takes about 20 minutes for them to get relief, but you're not going to find that with your kids. Choking, it's pretty universal. I can't breathe. So if you see this, you should be calling 911 while you're trying to do a Heimlich maneuver. Everybody knows how to do a Heimlich maneuver. You go to the diaphragm, hand here, second hand here, and thrust. That's if you can get around that person. So if you can get around that person, that's what you're doing. If you can't get around them, over a chair and back thrusts. Those are a couple pictures. If the person's small enough, you can put them over your knee and back thrust. So bleeding is pretty easy. You guys probably deal with that a lot. If you can cover it with a Band-Aid and it stops bleeding, we're good. If it takes 5 to 10 minutes, okay, I guess that's okay, but you know that's highly infectious. So at 5 to 10 minutes, if you're not having success stopping bleeding, we need to do something different. We need to call parents, see if they can come get them, and the parents can make a decision on where they go from here, but we need to stop bleeding. Nosebleeds, everybody knows, is pinch. If those kids aren't willing to pinch long enough to stop the nosebleed in your classroom, they probably need to go to the office. They need to pinch longer. And if we can't get them to stop nosebleeds in 5 to 10 minutes, we need to call home and see what's going on. Seizures. Everybody knows about seizures. Most of the kids, by the time they get to this age, pretty well controlled them with oral medications. They take those 2 times a day at home. The doctors have a hard time in the beginning of seizure diagnosis getting just the right medicine to keep them from seizing, but not too much to make them really sleepy. So hopefully by this time they've managed that. All we're really talking about is breakthrough seizures. Breakthrough seizures occur usually because of too much heat, too much light, too much noise. If those things occur, they can be triggers to causing seizures. Seizures come in 3 parts. The first part is an aura. That's where the child is starting to have misfirings in their brain, and they might do or twitching or itching or movement of their head. That's the beginning. Sometimes we can take a loud noise and get their attention, or we can look right in their face and call their name if you happen to see that. If you don't see that, they're going to go to the second part. What we're talking about is a grand mal seizure. That's tonic-clonic movement. If they're sitting, they could fall out of their chair. The third part of this is the postictal or after. That's their rest stage. They're going to be very difficult to have conversations with. All their energy has been spent having that seizure. So right now I'd like to show you a 6-minute video on that. If I know what I'm doing, maybe you need to help me. I want to minimize that and pick up the other one. Thank you. This is how we care for students that have diastat ordered in their plan of care to interrupt the seizure. Diastat is diazepam, diazepam is Valium, it's the drug of choice. That arrow, yeah.
Consider. Sometimes children with seizure disorders can have prolonged seizures. Longer seizures may contribute to complications. Depending on the student's seizure emergency plan, medication for prolonged seizures may be needed. Given that when a child is having a seizure, it can be a stressful situation, it is highly recommended that you familiarize yourself with the student's seizure emergency plan beforehand. Store the seizure emergency plan in a location that is easily accessible during a seizure. The correct dose of rectal diazepam ordered by the healthcare provider should be locked into place on the device by the dispensing pharmacist. This is evident when the green "Ready" is visible. Be sure to check expiration date on the medication package. Remember to keep healthcare information confidential. First aid for a seizure. Call for assistance if someone else is present. Place the child on a flat surface, such as the floor, being sure not to move the child any more than is necessary. Turn the child onto their side to allow vomit or phlegm to be expelled rather than inhaled. Place something soft under the child's head to protect them from injury. Ensure the child's airway is not obstructed. Loosen tight clothing around the child's neck. Do not restrict the child's arms or legs. Ensure there is no furniture or objects close to the child that could injure him or her. Review the child's seizure emergency action plan. Gather the emergency medication and needed supplies in case the seizure lasts longer than the designated time frame. Procedure for medication administration. Identify that symptoms of a prolonged seizure are present and that, based on the child's seizure emergency plan, medication needs to be given. Note time of seizure onset. Call for assistance if you have not already done so. Assemble supplies and place on a clean surface. Check the medication kit and the medical order to be sure it is, for the right child, the right medication, the right dose, being given at the right time, and being given by the right route. Also check to ensure the medication has not expired. Follow the student's healthcare plan and ensure the appropriate amount of time has passed prior to administering the student's seizure medication. Ask that another school staff person call 911 or emergency medical services and notify parent. Wash your hands if possible. Put on gloves. Recheck the medication kit and medical order to be sure it is for the right child, the right medication, the right dose, being given at the right time, and being given by the right route. Make sure the delivery device is in the ready mode. While providing the student with as much privacy as possible, remove clothing from buttocks and drape the buttocks with a blanket, pillowcase, or other barrier. Push up on the cap with your thumb and pull to remove the cap from the syringe. Open the package of lubricant. Lubricate the tip by inserting it into the lubricating jelly. Move the student to a sideline position with the upper leg forward so the rectum is exposed. Using non-dominant hand, separate the buttocks to expose the rectum. Using dominant hand, gently insert the syringe into the rectum until the rim is snug against the rectal opening. Push the plunger in, slowly counting to 3 until the plunger stops. Hold the syringe in place after inserting the medication and count to 3. Remove the syringe from rectum. Immediately hold the buttocks together and count to 3 again. This helps keep the medication from leaking out. Keep the student on his or her side. Keep blanket, pillowcase, or other barrier in place to provide privacy for the student. Note time of medication administration. If alone and you have not already done so, call 911 or emergency medical services now. Monitor seizure activity and respiratory effort. If breathing stops, begin rescue breaths. If breathing and heartbeat stop, begin CPR. Once rescue squad arrives, inform them of medication administered, including type of medication, dose, and time. Remember to dispose of all used equipment and medicine safely out of the reach of children. Remove gloves and wash hands. Document the date, time, and dose of medication given, in addition to what was observed during the seizure. Follow up with the parent or guardian and healthcare provider as needed.
Any questions about that administration?
Administration of glucagon.
We could do that one later. Let's decide if they want that one, if we have time. So you notice that the student was on their left side. That's the resting side. So whenever there's an emergency, it's a good idea to put someone on their left side for resting. It's easier on their heart. This is the seizures usually stop before you have to give the medication, but that particular order was 5 minutes. You'll need to be familiar with when do you give the medication. Some doctors say 2 minutes, some say 5, some say 10. So you should know what your student's plan of care says for the administration of the medication. So if you got lucky and it was 4 minutes and the seizure stopped, you are not giving Diastat. Everybody okay on that? Don't care about those. So there's also some students who might have a vagal nerve stimulator, and it looks like a pacemaker that sets in underneath their skin, and then there's a lead that goes to their vagal nerve, and the idea is it's magnetized. They may have an apparatus on their wrist that is the other side of the magnet, and they may swipe to stop a seizure. Those are usually in our special needs classrooms that we see kids with VNSs. CPR, it's just important. If you have the opportunity to take a CPR class, it's a good idea. Diabetes, everybody with me so far? You have students that are diabetics. What we worry about with diabetic students is low blood sugar. It's a medical emergency. Type 1 diabetes means that you were born with a pancreas and it produced insulin, and at some point it stopped producing insulin. Not really sure why or how, but it stops producing insulin. We have a gentleman who's in his late 30s. He brought his 5-year-old to start kindergarten and told us that his 5-year-old had been diagnosed since 9 months of age. 3 months before that, his dad was diagnosed with type 1 diabetes. So it's not necessarily about age, but most frequently we see type 1 as children. That means that he and his son do not produce insulin. Insulin is necessary that when you eat food, carbohydrates, that those go into your mouth and it gets digested, and that sugar, carbohydrate, has to get inside the cell. The way it gets inside the cell is by insulin. I call it the car that drives it into the cell. Without it getting into the cell, it just butts up against the cell, and you see very low energy people. If you see a diabetic student that's heads down and they're drooling, it's already too late. So the way that we fix this is we make sure that they have food, that they have carbohydrates particularly. All diabetic students should have a go box. I don't know what that means. It could be a lunch pail, it could be a cinch sack, it could be their backpack, but in that they should have their glucometer, which measures their blood sugar, and the supplies necessary. They should have their insulin. They should have rescue medication. They should also have water in there and anything else that they're going to need to take care of themselves. It's really important that if you have a diabetic student that comes to your classroom, you know where to get that go box, because you can't help a diabetic without their go box. Go ahead.
Do they leave it in their room?
It just depends on those students. Some of the students leave them in, it depends on who they are and what accommodations we're making for them. Usually they carry that with them wherever they go. If that's in their backpack and they're in your classroom, that could be in their locker. I honestly don't know where it is. You have to know where that go box is to help them. Those kids are protected by the American Disabilities Act. That's their civil rights, that they can test where they want, they can drink water, they can use the bathroom, they can eat. So you gotta figure out who your kids are. It's different with every classroom. Some of our diabetic students in elementary school go down to the office. These kids never go by themselves. They're always accompanied by an adult.
Our students, all of them, so far, the paperwork that you have, they carry with them.
I just don't know how, and I know if they have it or don't have it, if they left it at home, they didn't.
Most of them carry it in their backpack.
They'll let you know. I have students that hour to let me know if they should be reading the library because of that reason.
So I don't know what your policy is. Again, remember, I'm not the boss of the world, but if I were running that, if a student didn't have their go box and they're diabetic, I would walk them to the office and call their parents and get their stuff then. That's not okay for a diabetic student to be in school without their stuff. Okay, that's low blood sugar. Low blood sugar is a specific number to that student. Most cases, most of the kids are covered by the Beaumont Pediatric Endocrinology Group. They put down that 65 is the low number. Normal blood sugar for you and I after we go to bed at night, we go to bed at 10 o'clock, presumably we hadn't eaten since 6. So that's 12 hours of not eating when we get up at 6. Our blood sugar should be between 80 and 100, period. If it's not, then something's not working right in our bodies. If it goes to 120 or 140, we could be pre-diabetic. Because after 12 hours of fasting, you should be back to normal blood sugar. So these kids, a lot of times we keep them at about 150, 180, sometimes 120, depending on where they are. But if they get to 65, you're in big trouble. Our plans of care give them 2 challenges. 15 carbs to bring up their blood sugar to 65 to 80 or 80 and above. 15 minutes. If it's not up, we do a second challenge. Another 15 carbs. If it's not up after 15 minutes, Mom and Dad, we're not having success, you need to get here. If they're not here in 15 minutes, it's a trip to the emergency room by 911. I can't figure out if they're going to be okay or not. But low blood sugar, if they failed 2 challenges, I don't know what's going to happen. It makes me very uncomfortable. Make sense to everybody? High blood sugar is a long-term problem. That's where high blood sugar does its destruction. It destroys kidneys, liver, lungs, brain, all that kind of stuff. That's why those type 2 diabetics, those are those of us post 40 that put on a little bit of weight, and we don't always eat how we're supposed to, we don't sleep good. Pretty soon we're eating stuff and our pancreas just says, I don't care what you eat, I'm resistant to giving you the insulin you need to process food. And the blood sugar starts to come up. When that's the case, we have to give medication, or we can make choices, lifestyle choices, where we exercise and we lose weight, and that can bring our blood sugar down. We can fix it. We can fix type 2. We can cure it. We cannot cure type 1. No cure for it. Any questions about that? If blood glucose gets too low, and we can't get it up, and that student starts to, their head goes down and you can't get them awake, they can't respond when their blood sugar gets so low. So they can't, you can't say drink this. They can't swallow. They can't even move their lips to do that. You have to have glucagon. That's in their go box. Every diabetic type 1 has to have glucagon. It's how we rescue an unconscious person from low blood sugar. It comes in a syringe with water in it. Comes with a vial that has powder in it. You have to marry the two together, inject the fluid into the powder, reconstitute it so it's all liquid, pull it back up through the syringe, and pop them in the side of the leg through their clothing, just like an EpiPen, but not darting, just pushing. And by that time, one of your friends should have called 911 and EMS should be here. This is a big deal. That's low blood sugar. Any questions? Almost done. This is just for how do we give fluids and food to students with tubes. That's just a picture of how it's done. A lot of your kids and we're getting more and more kids in general population that have been fed by tubes. They may still have a Mickey tube. So it actually is a tube that goes, a device that goes through into the stomach. Strains and sprains, I'm sure you all know how to do that. Universal precautions require gloves, hand washing. If you need masks, you need to wear them. Bloodborne pathogens, all body, I'm sorry, go ahead.
I'm just wondering, it's like a two-part question. A, do we have any rescue glucagon anywhere? No. And B, is anybody checking to make sure that our diabetic students have it? Because we had a kid with seizure disorder who had a seizure, did not have any medication, continued not to have medication for quite a long time. And so if we don't have rescue glucagon, is anybody making sure?
Is it two different things? Is it a diabetic without glucagon and a seizure patient without diastat? Is it two? Is that? Am I understanding that?
I'm just saying that we've had instances in the past where the kids need it, but if they don't have it with them.
Glucagon is, there's just no excuse for not having glucagon. So if they don't have it, if the world were mine and I were the boss, they go home until mom and dad get them glucagon. It's as simple as that. I can't rescue somebody without glucagon.
Yeah, I did that last year. I had a student who was diabetic and he's like, I forgot my stuff, and I'm like, you need to go home, and he's like, you're right.
Good.
So he went downstairs and called his parents. I mean,
yeah, it's not an option because it's Murphy's Law, and it's going to be that day that student. When it comes to diastat.
We should be asking our diabetic students.
Yes.
Where's your go bag?
Yes.
Where's your glucagon? Show it to me.
Yep.
I mean, obviously in the privacy, you wouldn't do it in front of class, but I mean, that's
You're their advocate. You're their advocate. So why not know?
And if they don't, then do we direct them down to you? Okay.
Seizures are a little bit different. Not every student who has breakthrough seizures has an order for diastat. It might be a 911 call. That's why you need to look at the plan of care to see what it is. So if they don't have seizure medication, it's a 911 call when you have a grand mal seizure. None of us know what caused that, what's going on. And you guys are not in a role of assessors. You're not medical professionals. You are interventionists. So you're given a recipe card, which is your plan of care, and it says, if this, do that. And that's all you have to follow. Does it make sense? That's really the bulk of it. Any other questions? We made it. 30 minutes. You're welcome.